Welcome to the debate. Today we're focusing on one of the most significant strategic imperatives in modern healthcare, the shift towards integrated community-based care, what many are calling the home-first approach. This includes models like hospital at home, urgent community response teams, and other rapid response services. The goal, of course, is to provide acute care outside of traditional hospital walls, promising lower costs, fewer readmissions, and crucially, preserving a patient's function and independence.
And the promise is enormous, I agree. But as our source material makes abundantly clear, moving these services from, pilot schemes to full, scalable effectiveness is riddled with systemic challenges. We're really discussing the gap between aspiration and reliable delivery.
Absolutely. And that leads directly to our central question of implementation priority. To successfully scale and maximize the effectiveness of these sophisticated community crisis teams, to truly make them reliable and universal, must the system primarily focus on rigorous internal operational structures, and I mean the essential mechanics here, mandated protocols, standardized team mix, clinical efficiency, and data capture, or...
See, I come at it from a different way. Before we optimize the clinical machine, we have to address the system that feeds it. My position is that the necessary first priority must be intensive external awareness and simplified referral pathways. A perfectly designed internal service is, it's irrelevant if the intended users and referrers, the GPs, the community teams, the care homes, and critically, the patient's carers, cannot reliably, easily, and confidently access it. We have to eliminate that referral friction first.
I see why you prioritize accessibility, but I do wonder if we're putting the cart before the horse. My argument is rooted in reliability and trust. If you pump volume into a service that is structurally unsound, you will just accelerate its failure. The evidence consistently demonstrates that the failure of rapid response systems often stems directly from critical internal flaws, things like ineffective team dynamics, poorly defined roles, crowd control issues, and inadequate education and training. If that core mechanism is unreliable, external referrals, no matter how simple the pathway, will quickly dry up because the critical trust among clinicians and users is lost. The service has to be verifiably capable first.
Trust is paramount. I completely agree, but the evidence shows that internal capacity is frequently compromised by external systemic failures. Take the rapid response teams, the RRTs. We see documented instances where nurses activate an RRT not because the patient's clinical condition warrants that immediate crisis team skill mix, but simply because they're using the team as a workaround, a way to, and I'm quoting here, get an actual physician in the room when they can't get a hold of the physicians through standard channels. I mean, that's a profound breakdown in broader communication and collaboration, forcing an inappropriate referral. The internal team is destabilized before they even walk through the door because the external systemic pathway is broken.
That's a very important observation about systemic strain, but fixing the external pathway only exacerbates the challenge if the internal structure is fragile. To achieve the required level of high-quality, rapid delivery demanded by Home First, success really requires mandated operational structure. For example, the guidance for urgent community response teams pushes for them to operate in a truly interdisciplinary way. That means staff must be trained and authorized to take on aspects of each other's traditional professional roles, to optimize skill use across the team. Furthermore, systems must implement rigorous, mandated performance data submission, data that tracks outcomes and service utilization, to enforce accountability and allow system leaders to monitor performance trajectories consistently. You need that structural, verifiable quality control before you can handle increased volume.
And while I'd appreciate the need for operational accountability, the sheer lack of awareness acts as a throttle on any potential scaling. The awareness gap affects not just clinicians, but the public and carers. Look at the feedback from users of joint emergency teams, or JETs. Carers often report being, quote, unclear or unaware of what services JET is responsible for. Crucially, they fail to receive necessary follow-up information and simply don't know what sustained support they are entitled to. This communication failure restricts informed external decision-making, and it just perpetuates fragmented care. If the people on the front line, the family carers, the community nurses, don't understand the service's scope or how to access it, the highly functional internal structure simply remains a well-guarded secret.
Let's pivot to the very core of that internal capability, team structure. I'd argue that the necessity of highly integrated care demands fluidity in team composition. The goal is person-centered care, right? Which often requires breaking down traditional professional boundaries. The UCR guidance champions this interdisciplinary model. We even see sophisticated technology being deployed, like advanced resource allocation software, to optimize the team's skill mixes dynamically based on immediate caseload needs. This moves away from rigid job descriptions toward maximizing clinical utility, which is essential for rapid, sophisticated community care.
I agree that interdisciplinary collaboration is the ultimate clinical aspiration. But aiming for maximum fluidity before you achieve foundational clarity is just inherently risky. The literature on high-performing teams, including RRTs, confirms that performance is impaired by poorly defined roles. If internal team members are unclear on who holds the ultimate responsibility for a complex decision, hesitation sets in and patient safety is risked. And externally, that lack of clarity translates directly to a loss of confidence. When carers of JET users don't understand the specific roles of the staff or what they're authorized to deliver beyond the immediate crisis, they feel disempowered and question the entire service scope. Clarity of roles, communicated both internally and externally, that has to be established before you can maximize interdisciplinary fluidity.
But clarity doesn't necessarily mean rigidity. We're talking about highly skilled, advanced clinical practitioners who maintain professional autonomy while operating within clear, shared protocols. The goal of the multidisciplinary team, the MDT, it's not fixed job roles forever, but holistic care achieved through joint training and shared practice. If we focus too heavily on rigid definitions just to satisfy external partners, we sacrifice the MDT's critical ability to shift and adapt rapidly in a crisis, which is the defining characteristic of a successful home-first model. The flexibility is the value proposition.
Flexibility is the aspiration, but the evidence shows confusion undermines the mission far too frequently. The necessary level of inherent trust and shared knowledge required for that flexibility to work only emerges through sustained investment and joint training across different professional teams. Simply mandating a team structure is insufficient. When we look at the activation barriers for RRTs, the issues often cited aren't solely technical, they're cultural. Things like fractured relationships between nurses and doctors. That cultural chasm is what leads to hesitation and delays. We need foundational, cross-disciplinary training that builds trusting relationships, allowing internal clarity to emerge organically, rather than relying on an organizational chart or some policy mandate alone.
Well, that brings us directly to the challenge of increasing referrals, particularly from key partners like general practitioners, non-emergency telephone services, and care homes, which is necessary for scaling. If internal rigor is the priority, then mandated, consistent data collection is the engine for achieving that scale. By legally requiring submissions that quantify community service utilization and outcomes, system leaders gain crucial intelligence. They can track metrics like non-emergency telephone referrals and benchmark performance, for instance, ensuring teams meet the minimum threshold of responding to 70% of high-acuity referrals within 2 hours. Data provides the quantifiable mandate for leaders to identify capacity gaps and force investment, which is essential for attracting and retaining GP referrals.
Monitoring compliance and collecting performance metrics are, administrative necessities, but they don't address the underlying cultural resistance or systemic fragmentation that chokes referrals at the point of origin. We can mandate data submission all day long, but that data merely reflects the problem. It doesn't solve the provider's hesitation. The key gatekeepers are often cultural provider attitudes, fractured relationships, and clinical uncertainty leading to unnecessary hospital admissions.
I think data gives us the essential roadmap, though. It allows us to pinpoint precisely where the cultural resistance is manifesting. If the data shows a persistent failure to hit referral targets from a specific geographical cluster of primary care physicians, system leaders are compelled to look at that cohort and implement targeted, data-driven solutions, be it co-location shared IT systems or specific joint training sessions tailored to that failure point. Data provides the political and financial imperative for culture change, which otherwise just remains an abstract problem.
The procedure itself often acts as a significant structural blocker, irrespective of data mandates. Many community crisis teams, while adopting a progressive no wrong door policy, still require a cascade of verbal handovers, written referral forms, and detailed triage protocols that inherently act as procedural barriers, particularly for busy GPs. Focusing purely on mandated data collection masks the need for hands-on, sustained investment in joint training across multidisciplinary teams, as the sources explicitly recommend, to foster truly collaborative cultures where the default decision is easy referral rather than procedural compliance. The culture needs to want to refer, not just be monitored for failing to refer.
We both agree collaboration is necessary. But I maintain that external awareness and seamless access are fundamentally functions of system design, not just marketing or simple communication. Consider high-performing integrated systems globally. Their model ensures coordinated, high-quality care through deep structural integration, the health plan, medical groups, and hospitals working together, all supported by unified data systems. Access becomes seamless, and awareness is inherent because the system presents as a unified, predictable entity. The solution to low awareness is comprehensive system leadership that works to overcome cultural and financial challenges globally, unifying the patient journey.
That structural alignment at the executive level, however impressive, frequently fails to filter down to the user experience, creating what we might call the last mile problem. The caregiver experience with the joint emergency teams perfectly illustrates this. Despite the service being recognized as effective in providing timely and crucial support in the immediate crisis, the subsequent communication failure is severe. Carers face immense barriers knowing what support is available next. The lack of follow-up or clear signposting to other services creates a fragile environment where carers feel they have, quote, no choice but to just get on with it after the crisis team leaves. If we cannot clearly communicate the benefits and pathways solving the awareness problem and ensure sustained handoffs and follow-up, we fail the patient beyond the initial acute intervention, regardless of how integrated the organizational charts are.
That breakdown is certainly unacceptable, but it speaks to a gap in internal standardization, specifically mandated referral and discharge protocols for long-term management, which brings us right back to operational rigor. The hospital-at-home model explicitly includes protocols for robust handoff to the primary care physician and requires the acute team to maintain oversight for at least 30 days post-discharge. This indicates that sustained support must be built into the operational protocol and monitored via the same integrated data systems that track costs and clinical outcomes. It's an internal protocol failure, not just an awareness marketing issue.
That assumes full engagement from the primary care physician and an empowered, informed carer, which the evidence shows is often lacking due to poor communication. When the service remains opaque at the user level, the system breaks down at its weakest link. For the home-first model to truly achieve its ambition of personalized, sustained care, we have to prioritize making the service accessible, understood, and usable for the surrounding ecosystem of GPs, carers, and community teams first. We must focus on ease of entry and sustained support for the user, ensuring the best clinical route to acute community care is also practically the easiest route to access.
I maintain that while the challenges of communication and external awareness are valid, the reliable function of the service, its capacity to consistently deliver high-quality, rapid care, must be established internally first. The evidence repeatedly ties poor scaling and failed performance back to internal dysfunctions: poor team dynamics, inadequate training, and unreliable data capture. Structural integrity, mandated MDT composition, adherence to rigorous data requirements, and refined operational protocols is the essential foundation upon which reliable expansion must be built. External access is only valuable if the service you access is guaranteed to deliver on its promise.
My concern is that focusing too intensely on internal structure risks creating a highly efficient silo that is detached from the day-to-day realities of its external partners. The evidence demonstrates that even existing structural improvements are critically undermined by poor external understanding and deep cultural barriers to activation. Success in the home-first model requires flipping the priority. We need systemic engagement and awareness, making the integrated service understandable and seamless for external partners, the carers, the primary care physicians, the community teams, to ensure that we successfully capture the appropriate high-quality demand and transition patients toward long-term integrated health management.
The tension between perfecting the internal clinical machine and simplifying the external referral levers is clearly the defining challenge in scaling integrated care.
Indeed, the ultimate goal remains achieving person-centered coordinated care, moving from fragmented, crisis-driven responses to personalized, outcome-focused support. The sources reveal that whether you begin by optimizing the internal processes or by clearing the external path, continuous, rigorous challenge and evaluation of both pathways are necessary to fully realize that ambition. We've really only begun to explore the complexity inherent in moving acute care out of the hospital.